This is Kathy Knipfer, instructor for Nursing 2203, recording the Pediatric lecture for Chapter 44, Genitourinary Dysfunction. Assessment of the urinary and renal system includes physical examination, history taking, observation of symptoms, as well as laboratory, radiologic, or other evaluation methods. Here is a refresher on the anatomy of the kidneys and nephrons. Urinary tract infections are one of the most common conditions of childhood. It's often impossible to localize the infection, so we just use the broad term urinary tract infection or UTI. There's a high incidence of infection among uncircumcised boys younger than 3 months. Types of urinary tract infections. Recurrent means repeated episodes. Persistent means that there is bacteria in the urine despite antibiotics. Febrile typically indicates pyelonephritis. Cystitis means inflammation of the bladder. Pyelonephritis involves the upper urinary tract and kidneys. Urosepsis means that there are urinary pathogens in the blood. A variety of organisms cause urinary tract infections. The most common is E. coli, also Proteus, Pseudomonas, Klebsiella, Staph aureus, Haemophilus organisms, and coagulase-negative staphylococci. Anatomic and physical factors that are associated with urinary tract infections. The structure of the lower urinary tract is believed to account for the increased incidence of infections in females. The single most important contributing factor for urinary tract infection is stasis. Vesicoureteral reflux, anatomic abnormalities, dysfunction of the voiding mechanism, or bladder compression are conducive to infection. A child should be evaluated for a urinary tract infection if there's a strong or foul-smelling urine, if there's frequency or urgency, or if a toilet-trained child is incontinent. Diagnostic tests for urinary tract infections include urine culture and sensitivity, suprapubic aspiration, percutaneous kidney taps, bladder washout procedure, ultrasonography, voiding cystourethropy, IV pyelography, and then renal scans. Therapeutic management of urinary tract infections include eliminating the current infection with antibiotics, identifying contributing factors to reduce the risk of recurrence, preventing systemic spread of the infection, ensuring adequate or increased fluid intake, as well as preserving renal function. Nurses should teach about prevention of urinary tract infections. The nurse should instruct parents to observe regularly for signs of infection. They should tell the patients that simple hygiene habits should be routine. Teach patients to cleanse genital areas from front to back. Encourage sexually active adolescent girls to urinate as soon as possible after intercourse. Obstructive uropathies are structural or functional abnormalities that obstruct normal flow of urine. Backup of the urine above the obstruction causes hydronephrosis. The condition may be acquired, unilateral, bilateral, complete, or incomplete. Early diagnosis and surgical correction are essential. This diagram provides examples of obstructive uropathy. You will notice strictures and stenosis in the diagram. Defects of the external genitourinary tract are serious conditions, primarily because of the psychologic impact on the child. Surgical repair is required for major anomalies of the lower genitourinary tract. There may be psychologic problems related to genital surgery. It has been recommended that surgery be accomplished between the ages of 6 and 15 months to minimize this psychologic impact. The signs and symptoms of nephrotic syndrome or nephrosis are proteinuria, hypoalbuminemia, hyperlipidemia, edema, as well as massive urinary protein loss. This slide represents the sequence of events in nephrotic syndrome. Types of nephrotic syndrome include primary disease, also known as idiopathic nephrosis, childhood nephrosis, and minimal nephrotic syndrome. The second type is secondary nephrotic syndrome that is associated with glomerular damage. The third type is the congenital nephrotic syndrome that is an autosomal recessive disorder. Pathophysiology of nephrotic syndrome. The glomerular membrane is normally impermeable to large proteins. With this syndrome, it becomes permeable to proteins, especially albumin. This causes albumin to be lost in the urine, hyperalbuminuria. The serum albumin decreases, hypoalbuminemia, and fluid shifts from the plasma to the interstitial spaces. Therapeutic management of nephrotic syndrome includes supportive care, reducing the excretion of urinary protein, reducing fluid retention in the tissues, preventing infection, and minimizing complications related to sepsis. Children with nephrotic syndrome are usually treated with corticosteroids such as prednisone. As a result, these children are at a higher risk for infection. Nutrition needs to be addressed because of the loss of appetite. Sometimes salt and fluid are restricted. Children usually adjust activities according to their tolerance levels, but they may require guidance in selecting play activities. Continuous support of the child and family is one of the major nursing considerations. Parents should be taught to detect signs of relapse that should be reported. They may be instructed to test urine for albumin, administer medications, and just provide general care. They should be instructed also regarding avoiding contact with infected playmates. But the child Acute glomerulonephritis may be a primary event or a manifestation of another disorder. Acute post-streptococcal glomerulonephritis is the most common of the post-infectious renal diseases in children. A latent phase of 10 to 21 days occurs between the streptococcal infection and the onset of the clinical manifestations. Glomerulonephritis symptoms include oliguria, edema, hypertension, hematuria. Bleeding in the upper urinary tract causes urine to appear smoky. Another symptom is proteinuria. Increased amounts of protein reflect increased severity of renal disease. Prognosis of glomerulonephritis. Almost all children with a diagnosis of acute post-streptococcal glomerulonephritis recover completely. Specific immunity is conferred. Subsequent recurrences are uncommon, but some children have been reported to develop chronic disease. Care management of the child with glomerulonephritis. The nurse would monitor vital signs, fluid balance, and behavior. Vital signs provide clues to the severity of the disease and early signs of complications. The nurse would manage edema by monitoring daily weights, intake and output, and also abdominal girth measurements. For most children, a regular diet is allowed, but it should contain no added salt. So they may be on a low sodium diet as well as fluid restriction. The nurse would also monitor for infections. With hemolytic-uremic syndrome, the primary site of injury appears to be the endothelial lining of the small glomerular arterioles. Diagnostic criteria includes anemia, thrombocytopenia, and renal failure. The most consistently effective treatment is hemodialysis or peritoneal dialysis. With prompt treatment, the recovery rate is about 95%. Wilms tumor is also called nephroblastoma. It is a malignant renal and intra-abdominal tumor of childhood. It is 3 times more common in African American children. The peak age at diagnosis is 3 years, and it is more frequent in boys. Wilms tumor probably arises from a malignant undifferentiated cell capable of initiating the regeneration of an abnormal structure. Most children with Wilms tumor are brought to the practitioner because of abdominal swelling or an abdominal mass. Therapeutic management includes surgery and chemotherapy with or without radiation. The most important nursing alert is do not palpate the abdomen. Manipulation of the mass may cause spreading of the cancer cells. The nurse may need to give explanations about radiation therapy and chemotherapy. They may need to explain benefits and side effects. Renal failure can be caused by inadequate perfusion, kidney disease, or urinary tract obstruction. Chronic renal failure may be the result of long-standing kidney disease or a congenital anomaly. With acute renal failure, the kidneys suddenly are unable to regulate volume and composition of urine. It is not common in childhood. The principal feature is oliguria. The oliguria is associated with azotemia, metabolic acidosis, and electrolyte disturbances. The most common cause in children is transient renal failure resulting from severe dehydration. Acute renal failure is usually reversible. The infant or child is usually already critically ill. Laboratory measurements are important during renal shutdown. Things that would be measured would include BUN, serum creatinine, pH, sodium, potassium, and calcium. Therapeutic management would include treating the underlying cause, managing complications, and providing supportive therapy. Complications of acute renal failure include hyperkalemia, hypertension, anemia, seizures, hypervolemia, and cardiac failure with pulmonary edema. Chronic renal failure usually occurs when more than 50% of the functional renal capacity is destroyed. It begins when diseased kidneys cannot maintain normal chemical structure of body fluids. There is a progressive deterioration over months or years until it develops into the clinical syndrome called uremia. Potential causes of chronic renal failure include congenital renal and urinary tract malformations, vesicoureteral reflux associated with recurrent urinary tract infections, hereditary disorders, chronic pyelonephritis, chronic glomerulonephritis, anaphylactoid purpura, and lupus erythematosus. Signs and symptoms of chronic renal failure often emerge only late in the course of the disease. There is a severe reduction in the number of functioning nephrons. The onset of chronic renal failure is usually gradual. Initial signs and symptoms are vague and nonspecific. Refer to box 44-7 on page 1412 for clinical manifestations. Therapeutic management includes promoting maximal renal function, maintaining fluid and electrolyte balance, treating systemic complications, and promoting as normal and active a life as possible. If this condition develops into end-stage renal disease, dialysis and transplantation is the process of separating colloid and crystalline substances through a semipermeable membrane. Examples and methods would be peritoneal dialysis, hemodialysis, and hemofiltration. Peritoneal dialysis is the preferred method of dialysis for children. The abdominal cavity acts as a semi-permeable membrane for filtration. Warm solution enters the peritoneal cavity by gravity and remains for a period of time before removal. This can be managed at home in some cases. Hemodialysis requires creation of a vascular access and special dialysis equipment. It is best suited for children who can be brought to the facility 3 times a week for 4 to 6 hours. It achieves rapid correction of fluid and electrolyte abnormalities. Here is a picture of a child undergoing hemodialysis. Kidneys may come from living related donors, such as a parent or a sibling, or from a cadaver donor. The primary goal is long-term survival of grafted tissue. Of course, these patients would be on immunosuppressant therapy. And here's a question. What best describes acute glomerulonephritis? A. Occurs after a urinary tract infection. B. Occurs after a streptococcal infection. C. Associated with renal vascular disorders. And D. Associated with structural anomalies of the genitourinary tract. The answer is B, as in boy.